Hi, everyone. We're just going to give it a moment for people to connect before we officially kick things off. All right. Hello, and thank you for joining HHS's briefing on conservation strategies for IV fluids that are in shortage due to the damage to Baxter's North Cove facility. My name is Betsy Wien, and I'm the Public Health Policy Advisor in the Office of Intergovernmental and External Affairs here at the Department of Health and Human Services. This briefing is open to the public. However, the conversation should be considered off the record, and any press inquiries for HHS should be directed to the press office at media@hhs.gov. There will be time at the end for Q&A, so we encourage you to submit your questions using the Q&A function at the bottom of your screen at any time during the briefing. During today's call, you will hear from experts at CDC on the recently released Health Advisory Network Health Alert Network Health Advisory, as well as hospital and group purchasing organization leaders about strategies and best practices to conserve IV fluids that are in shortage. But first, I'd like to turn it over to Sarah Dupre, Counselor to Secretary Becerra.
Thank you so much, Betsy, and thanks to everyone for making the time today. We really appreciate your time as well as all the work you are doing in what we know are challenging circumstances. As Betsy said, I'm Sarah Dupre. I'm a counselor to the Secretary for Public Health and Science. We are pleased about the recent about Baxter's recent announcement and the progress they are making in order to get their facility up and running and to increase supply. However, we acknowledge that it may take time to refill the pipeline and get ourselves back to normal. These conservation strategies that we'll talk about today will still be necessary for at least a little while. So we wanted to bring you all here to talk about these strategies and lift up best practices. So thank you again for your attention, and I'll turn it back to you, Betsy.
Thanks, Sarah. And now I'd like to welcome Arjun Srinivasan, Deputy Director for Program Improvement at the Division of Healthcare Quality Promotion at the National Center of Emerging and Zoonotic Infectious Diseases at CDC.
Thanks, Betsy, and welcome to everyone. Thank you for joining, and especially thank you to our experts who are going to provide what I think is the meat of the presentation today. I wanted to join very briefly just to let folks know that CDC did issue a Health Alert Network Health Advisory, that's a mouthful, on this issue of the IV fluid shortage. We recognize that this is an extraordinary challenge for all of you as busy clinicians. This was the last thing that you needed, but it is a challenging reality of providing care right now. The health advisory that we issued attempts to bring together resources from a variety of different places. So there's links to resources there on conservation strategies, on assembling multidisciplinary teams, supply chain management, coordination with state and local health departments. Lots of resources hopefully pulled together in one place. So would direct your attention to it. If you don't have it and don't have a quick way to access us, please let us know. We can send it out with the summary of the presentation today. But those resources are there. So wanted to let folks know that we have tried to summarize. Perfect. It's in the chat now. We have tried to summarize a lot of information, bring it all into one place. So please, that is a resource for anyone who needs it. And we wanted to make sure that folks were aware of that resource, of the assembly of all of those different ideas, many of which we are here to learn more about today. So thank you for joining. Thank you again to the experts who are joining us today to provide some of the more technical and detailed insights into this. And we know this is a challenge, and we are all working together to try and address it. So with that, Betsy, I'll turn it back over to you.
Great, thank you so much. And now I'd like to welcome Gregory Pauly, Group President of Acute Care Services at Duke University Health System, and also President of Duke University Hospital and Vice Dean at Duke University School of Medicine. Greg, over to you.
Great, thanks, Betsy. So I thought I'd just share a little bit about what we're doing here at Duke. I will say it's a little bit of a compilation of conversations that we've had with many of our colleagues. So hopefully some of what we've come up with resonates with things that you guys have done locally at your institutions as well. So we at Duke have taken a number of steps to conserve our IV fluid across our clinical platforms. I'll talk about our conservation efforts really in two buckets. First is our emergency conservation methods, and these are ones that we have in place now, but will likely relax when supply levels return to normal. The second is our permanent IV conservation measures, and these are items that we have discovered through this process that we should probably change on a more permanent basis going forward. So for our emergency conservation methods, the first thing that we've done is we've centralized all of our supply and distribution of all of our IV fluids to closely monitor our available products. So what that means is that we've, in essence, cleared out all of our IV fluids from our floors and from our practices. So they no longer exist in Pyxis machines or tube-in processes or supply closets. We've left behind just enough for an emergency supply of IV fluid on each floor or practice. We've then updated our processes and protocols to eliminate IV fluid use, which is not clinically necessary. We've limited the duration of routine IV fluid orders. We also go through a daily process of reviewing by our clinical teams on any ongoing IV fluid use for clinical necessity. And then we also regularly review all of our maintenance fluids orders on each inpatient unit, especially for those patients who can possibly hydrate in other ways like orally using Pedialyte or Gatorade. We've also modified our guidance for use of sterile water for rinses and flushes, especially in our ICUs. We've allowed for bottles of irrigation fluids to be used as multi-use items for 96 hours in very specific patient care scenarios, such as wound care, dressing changes, etc. Our most common swap out has been using lactated ringers for normal saline equivalency as isotonic solutions. We've been swapping out bag sizes to decrease required dilutions for mixing drugs, and we have switched some meds from bag drips to push medications as well. On our permanent chart of things that we're doing to conserve IV fluids, we've made several order set adjustments to decrease fluid consumption when appropriate. We're allowing tubing changes every 7 days rather than every 96 hours. We're eliminating the keep vein open protocols to only when clinically appropriate. We're asking staff to not discard or replace fluids that were transported with the patient from either other facilities or other areas within the hospital. We're adjusting flow rates to accommodate for fluids for patients who are on PCA. And specifically in our peri-op areas, we're reducing the guidelines for patients to have nothing by mouth prior to surgery. We're reducing the PCA use for appropriate patients who can take oral pain medications. We're also decreasing the size of saline bags used. And then we've also introduced as part of the pre-procedure huddle, the review of IV fluids for each and every case. On a conservation basis, we're kind of hovering around 70–80% of conservation from our normal usage. And that seems to be holding well so far. Our days supply on hand, and we calculate this by dividing our daily starting inventory by the usage over the last 5 weekdays, so we don't include the weekends. And so our days on hand continues to sit about a week for most of our products, but there are several products though that we are very concerned about running low on, and we tend to watch those on an hourly basis. Our resupply levels still currently sit at about 40%. I know Baxter and a variety of folks are trying to get those up to 60%. We've also seen a fair amount of variation in products being delivered, and so we've come up with the notion that until we see it appear on our loading dock, we don't count it. And I think that's helped us to also be very frugal in how we've gone about conserving our IV fluids. I do want to send a special thanks out to our colleagues in the FDA for helping to relax some of the regulations on compounding. It has allowed us to partner with the Duke Vaccine Institute to manufacture large quantities of sterile water and normal saline. So we've not used any of that supply yet as it's still going through testing, but hoping this can serve as a backup supply for us in the coming days. And I know, like many of you, we've all kind of struggled with canceling cases, especially our elective cases. Early on in the process, we did end up canceling about 70 elective cases. That was over a 2-day period of time, just until we got a sense of what our IV fluid conservation efforts were going to be. Since then, we've been fortunate not to have to cancel any cases, but that is something that we do review on a daily basis. And so that's just a brief overview of what we've been doing at Duke. We certainly want to thank all the folks on this call who've helped to pull this webinar together. I think it's always great to share ideas with our colleagues as we're all trying to do our best to manage through this IV shortage. So thanks for having me. And Betsy, I'll turn it back to you.
Great, thank you so much. And now I'd like to welcome Haley Addis, with VP of Strategic Sourcing with Health Trust. Haley, over to you.
Hey, good afternoon, everyone. I am Dr. Haley Addis, VP of Strategic Sourcing at Health Trust. Health Trust is a provider-owned group purchasing organization. We serve 1,800 acute care hospitals and 70,000 alternate sites of care. Information provided by Health Trust is not intended to replace individual clinical decision-making, which is the sole responsibility of our providers. Over the past several weeks, we have continued to provide education and communication to our members to support conservation strategies with the goal of minimizing disruption to patient care. We believe that conservation is a critical strategy, regardless of whether you are a Baxter primary customer or not, to prevent shortages across the U.S. healthcare industry. In speaking with leaders across our membership, from large to smaller health systems or individual facilities, the implementation of following strategies have been impactful, and many are reporting 30 to 50% or higher reductions in utilization as a result. And similarly to what Greg shared, there are some of these practices that can be continued on a go-forward basis, even once the crisis has subsided. First, I think it's important to talk about leadership, communication, and education, as this has been a critical element to success. Many members have reported developing an IV solutions task force to collaboratively manage the shortage, and it involves key stakeholders across executive leadership, medical leadership, quality, infection prevention, other key service line leaders, supply chain, pharmacy, and clinical informatics. This task force is responsible for reviewing on-hand inventories, monitoring inventory burn rates, variability in utilization, developing communication and education plans, including tools for communicating effectively with patients, execution of conservation measures, and then, of course, developing crisis contingency plans and plans for crisis escalations. Leaders are assigned with responsibility for rounding in all areas, with the task of reviewing patients receiving IV fluids each shift to monitor and recommend discontinuation or utilization changes, as well as to continue to support education and communication and identify practices leading to waste or product expiration. Documenting and monitoring is important, including documenting and monitoring the implementation of conservation strategies, and monitoring supply utilization and following up on outliers. I've heard erring on the side of over communicating is important, using multiple modes of communication across the system. The mantra should be to stop and evaluate prior to placing orders with every bag change, shift change, or transition in care. So moving on to utilization strategies, of course, it is critical to use the oral route when possible for hydration, electrolyte replacement, medication administration, nutrition. When oral is not feasible, considering IV push or IM medication administration, or moving to commercially available, ready-to-use pre-mixed medications and parenteral nutrition when possible. Customers similarly are recommending to limit KBO orders, and if required, utilize the lowest rate possible. If patients are on continuous non-titratable medications, evaluating the potential to use those solutions as a carrier in place of KBO dedicated lines. Reducing bag size to 500 ml for pressurized hemodynamic monitoring lines. Reducing bag size for blood administration to 100 ml or IV mini bags. And then leveraging the electronic health record. Many have worked to build in algorithms and reporting capabilities to identify patients who are candidates for discontinuation of fluids, such as those who are receiving IVs on an oral diet with normal kidney function. Working with Pharmacy and Therapeutics Committee and medical staff committees to implement protocols to provide flexibility, such as IV to PO, automatic interchange policies, and interchanging solutions where clinically appropriate. Organizational success, of course, requires support from all disciplines, when working with key service lines to develop specific stewardship and conservation strategies. In the emergency department, one of the most impactful strategies has been just to evaluate clinical necessity prior to starting IVs. In the procedural areas, moving to oral hydration pre-procedure, using saline lock IV when possible for minor procedures, avoiding removing solutions from overwrap or spiking bags until needed to minimize waste, and limiting placing fluid in warmers. Irrigation solutions remain critically constrained, and the lack of available alternatives are currently presenting significant challenges for our members. So a couple strategies specific to irrigation, evaluating the utilization of irrigation solutions, restricting usage based on clinical evidence and guidelines, consulting with the surgical team to determine irrigation needs and to assess benefits versus risk on a case-by-case basis. If appropriate, consider using pre-mixed heparinized saline for back tables in irrigation. In arthroscopy cases, looking to reduce pump rates. And in urology, working with surgeons to confirm use of normal saline, glycine, or sterile water individually or in combination during the procedure based on product availability. In all cases, establishing goals with the surgeon for fluid irrigation to limit to the smallest bag and number of bags possible, and updating preference cards accordingly. Evaluating opportunities to eliminate devices that require irrigation solutions if an alternative technique is available, such as monopolar or bipolar electrocautery, and looking at the surgical case schedule 5 days out for planning and prioritization, and determining when delaying elective procedures may be necessary to conserve fluids for critical patient needs. The goal, however, is to conserve use whenever possible to avoid cancellation of cases. In dialysis, consistent with the nephrology societies, working closely with dialysis service lines and providers, including the outsourced providers, on conservation strategies, focusing on bag sparing over solution sparing, and limiting new starts of peritoneal dialysis patients. In labor and delivery, evaluating standards for oxytocin dilution and administration with the goal of reducing the number of bag size utilized. And administration of oxytocin 10 units IM may be considered for control of postpartum uterine bleeding. Some operational considerations, I know a few of these have already been mentioned. Our members continue to escalate and communicate concerns around not receiving their full allocations. So we are encouraging participation in routine calls with the primary IV solutions manufacturer representative in combination with your distributor representatives to collaborate and confirm allocation availability, status of orders, and expected delivery dates. Conducting daily inventory counts, consider consolidating inventory and distributing from a central location, and then also quarantining and holding expired solutions in the event approval is obtained for expiration date extension. We'd like to remind everyone to use caution when placing orders outside of traditional suppliers. Non-traditional suppliers should be vetted very carefully, and most of what we have seen have not really panned out to have adequate supply chain controls needed for medications. So with that, I want to thank you again for the opportunity to speak with you today, and I'll turn it back over to Betsy for the next segment of the presentation.
Thank you so much, Haley. And now I'd like to welcome colleagues from the Stanford Medicine's Children's Health to talk about some pediatric specific considerations.
Thank you, Betsy. I'm gonna start by sharing slide, just making sure that everyone can see my screen properly. My name is Shabnam Gaskari. I'm the Chief Pharmacy Officer here at Stanford Medicine Children's Health. I'm here jointly with Dr. Anna Lin. I'm turning it to Anna for introduction.
Hi, I'm Anna Lin. I'm the Assistant Medical Director for our Office of Emergency Management, which is a shared service across Stanford Medicine Children's Health and Stanford Healthcare. I'm also a clinical professor at the School of Medicine. I do receive funding for my work with the Pediatric Pandemic Network and the Western Regional Alliance for Pediatric Emergency Management. But I do want to say that the perspectives that I'm sharing here within this conversation are my own and do not represent the official views of ASPR, HRSA, or the Department of Health and Human Services. Shabnam, okay, great.
Okay, good. Good morning, everyone. Today I'll be discussing our response to the Baxter IV fluid disruptions. As many of you know, these disruptions has affected critical areas of many hospitals, including surgeries, IV fluid management, our parenteral nutrition, and our dialysis services. Our goal today is to review the coordinated conservation and medication strategy we implemented to address these challenges. At first, I want to give a shout out to our supply chain that they are the center of this very well organized mitigation strategy, and they are the main entity that pulling everyone together to make sure that we have enough to supply our patients. Very early on October 4th, we mobilized a group of physician, nursing, pharmacy, and supply chain stakeholder to get together to start discussing these our mitigation strategies. By October 7, we had prioritized the key pharmacy strategies, especially around conservation of still water. These efforts are rooted in collaboration across service lines to ensure that the most impactful measures are in place. Currently, our recommendations are under review and awaiting approval from a governing body, the recommendations that are tighter in clinical practice. Our strategy is centered around data-driven approach. We establish a centralized fluid management process, consolidate our procurement and distribution to better manage limited supplies. We are also leveraging multiple vendors to stabilize our supply chain. We are using non-Baxter opportunities and 503B companies that are out there as well. Our data-driven center played critical role, using real-time EMR to track usage and watch our prioritization closely, allowing to also notice which units are the high usage. And additionally, we are working closely with the clinical team to refine a statement protocols, and we are actively seeking approval from our governing body. I do want to bring a highlight note. At first, we had big, giant meetings to talk about our strategic collaborations, but we learned we need a smaller group. So pharmacy led a smaller group with clinical teams, including ORs, radiology, nursing, GI team, and dialysis team. We learned that we can foster collaborative and also evidence-based data mitigation strategy deliver. We do review our usage on a daily basis to make sure the strategies that we implemented are working or we need to change or align. These are some examples of the strategies that we have implemented. In clinical practice, we did start looking at our standby fluids, making sure that we can stop that practice anywhere that is acceptable. I think that was mentioned, shifting toward lactated drinkers from normal saline, prioritizing PO over an enteral route over IV route, consolidating holding IV fluid when in POs, and decreasing the NPO time. Prefer saline lock over the keeping the line open with the TKOs, and also using aliquot of normal saline made by pharmacy for areas, since we are pediatric, that rather than using a big bag. In parenteral nutrition, we had many conservation strategies. We consider dropping patient off the PN sooner. We decreased the actual concentrations, like as we concentrated the parenteral nutrition by increasing the intralipid and also protein to make it very concentrated, and using of less IV fluid. And also we start considering, should we ask patients to bring their home supply of parenteral nutrition to the hospital for usage. In prenatal dialysis, we looked at it. For now, we are conserving and keeping all the expired PD bags. We are working and thankful to FDA considerations of expansion of some of the expirations of some of IV fluids. So we are collecting all of those and making sure we keep our expired bags on hand until further notification. We worked with nursing, radiology, minimizing IV fluid all across. We have a frequent assessment of the fluid needs between pharmacy and nurses on a daily basis. And again, we keep expired IV bags. All of those mitigation strategies did came with the SBAR and a standard practice, and we would be more than happy to share with whomever wants if they reach out to us. With that, I do want to share some of example that we created in our EMR system to make sure that there is a bigger system effort that notifying our physicians or ordering residents that they are aware of these fluid disruptions. One of the example was making sure that the patient need PN, and if they are writing IV and PO orders, they make sure that if really needed or can be convert patients to PO. Another strategy was around the custom dextrose fluid, if the patient really needed, or we can supply patients with something maybe more of the PO hydration or something more available in hand hydrations. And another strategy was around IV to PO, the alert coming up to physician to making sure if patient really cannot take any PO medication. The special focus was on electrolyte replacement. I do want to say that at this point, I'm going to hand it to Anna, because our hospital kind of started to think that we are on the contingency planning, and we might need to start our incidents command center for the hospital. Having said so, I have very lucky that I work with Anna alongside, and I'm handing the presentation to her to explain more details on that. Anna, to you.
Hi, I was asked by Shabnam, and so thank you for having me to talk a little bit about an ethical framework for conservation measures. And really, we'll talk a little bit about not my ideas, but ideas that were put forth by the National Academy of Medicine around crisis standards of care. So we have moral obligation to actually equitably treat our patients with dignity and respect, and use individualized assessments and objective medical evidence to make our decisions, and allocate resources appropriately. And in addition to that, we have a duty to plan and steward the resources that we have available to promote instrumental value, as well as being transparent about those decisions. In addition to what we have here within the ethical framework that as outlined on this slide, there's also a moral obligation for consistency, so that we're actually applying a framework equally and consistently across healthcare entities or a healthcare enterprise, as well as proportionality, so that we're responding in kind to the crisis that's at hand. And then accountability for the decisions that we make. Next slide, please. Next slide, please. You all may know that the crisis care continuum goes from conventional, usual, everyday practice, which is our standard of care, to crisis care, where we're actually allocating the resources that we have available. And in between, we have this contingency care area where we're actually changing our everyday practice, but still providing functionally equivalent care. What we see is that as there is an increased imbalance between patient needs and resources, we actually have to make decisions that may increase the patient's risk of morbidity and mortality. Next slide, please. When we're talking specifically about this particular fluid disruption, we are actually most likely in contingency care already, because we are changing our usual practice to provide functionally equivalent care. I've listed some examples of conventional care, which it may be considered the permanent changes that we would want to make, just regular things that we can do that don't affect our standard of care. One would be an example that we have from our emergency department was that they were actually using IV fluids, not for IV fluids, but as weights. And so maybe using sand weights instead of actual IV fluid bags. Really, as discussed previously by other speakers, encouraging oral rehydration for acute gastroenteritis, and then applying the best practices for anesthesiology fasting guidelines, and centralization of inventory and using premixed mixtures, premixed medications. So all of these would be considered conventional care because you're actually not changing your approach to the patient. Once you actually change how you approach patient care and you're switching from your usual everyday practice, you are actually in contingency care. And so if you're thinking about how you're changing the administration of medications, maybe changing what you're using or extending shelf life, you're already in contingency care. And actually, this isn't a bad thing. It's because I think the longer that we can maintain contingency care and avoid crisis care, the better that we're in. And I would recommend, and I have recommended to our institution to actually enter into contingency care early so that we can actually take care of as many patients as possible for a lot longer. It is in this phase where you actually want to identify triggers and consider the activation of your hospital incident command system. And the reason why you would want to do that is to make sure that you are aligned and providing consistency of structure across either your healthcare enterprise or healthcare entities if you have multiple within your system. And the whole goal is to actually having to avoid making crisis care decisions such as the allocation of dialysis or parenteral nutrition, or actually having to withhold care with surgical case cancellations. I, I think I'll leave it here just to as a framework for folks to think through if you aren't already doing that, and hand it back to Betsy for questions and answering.
Great, thank you both so much for that information, and thanks to all of our speakers today for their expertise. We have time to take some questions, which you can pose using the Q&A box at the bottom of your screen. I'll also note that in addition to the speakers we have on today, we are also joined by colleagues from the Administration for Strategic Preparedness and Response, as well as the U.S. Food and Drug Administration to answer any questions that may come up. So one question we have is for Greg. Are there a couple of strategies or practices that have been most effective that you've found?
So I guess I would say I mean, there's been a lot of strategies. I think the one that has been most effective for us, quite frankly, has just been pulling all the fluid off the floors in the practices. I think very quickly it sent a message to the team that we were in crisis mode. And I think it also, by having it centralized, it required the clinical teams on each floor to review all of their IV orders and to go through it in a very judicious manner. And so I think because of that, we've probably more successful in our conservation methods than anything else. I think it's also caused a lot of innovation and creativity amongst our staff to think of other ways that we could think of mitigating this. But if I had to put my finger on one thing, it would probably be the centralization of all the IV fluids off the floors and concentrating that all in one location. So.
Great, thanks so much. For Shabnam and Anna, we got a question about what hospitals should do in states that do not recognize crisis standards of care or do not have crisis standards of care in place.
I think it's really challenging, right? I think, sorry, let me start from the beginning. I think what's really important is that whatever your conservation methods are, that they're actually following a framework that is endorsed by your institution. Because healthcare entities are going to actually get into trouble is if there's actually differential care being provided within a healthcare enterprise or a series of healthcare entities under a healthcare umbrella such as Stanford Medicine. And so having the consistency and not providing differential care is really important, even if you don't have a declared emergency or even if crisis care has not been invoked at the state level. So you can actually have some protection by having a equitable framework just within your healthcare entity, if that makes any sense.
Makes a lot of sense. Thank you. So for folks who are joining on the phone, we've received some questions that I answered in the Q&A box, but we are recording today's presentation and we plan to post it on the HHS YouTube webpage. It'll take a few days for that to be published, but once it is live, we will send out the email, or we will email out the link to all registrants, and folks should feel comfortable sharing this broadly. I'll pause to see if there are any other questions that have come in for our speakers or subject matter experts from FDA and ASPR. Well, if not, we can close out today's webinar a few minutes early. I want to thank everyone who submitted questions and to all of you for joining us today. Thank you also to all of our speakers and subject matter experts who were on the line for joining us. Hope everyone has a great day.